How we doing? I'm Dr. Ryan Weaver. I'm a clinical neurologist, also known as functional neurologist, also known as Doctor of Chiropractic and diplomate of the American Chiropractic Neurology Board. So, what brings me on today is I need to explain better that what I've been taught from the Carrick Institute and Frederick Carrick that we refer to and will keep referring to as clinical neurology has nothing to do with physical therapy. And the reason I say this and the reason I'm making the video today is I'm reaching out to different sports athletes, sports agents, and in the whole world of athletics. And what I'm been told is, well, if we need physical therapy, we'll contact you. That to me is a sign that I have to actually teach a little bit more, and hence the video. So bear with me here, and we're going to actually talk about clinical neurology, or also what's called functional neurology. So functional neurology is typically most often based with treatment that integrate into the vestibular system. And so the vestibular system is part of the central nervous system. That's what I'm discussing, the central nervous system, which is really brain-based stimulation. So when we're talking about an athlete that has maybe a knee issue, where the world lives at is the world lives in let's MRI the knee, let's look at the range of motion of the knee, let's treat the knee, and it that seems like it makes sense. And I would say most times that the it's pretty effective, right? So the problem is when it's not effective, what does that mean? Well, typically it means that that athlete's career is over. This is really where the fruits are and where there can be much more improvement. So let me try to explain why. When we look at it, doesn't even matter where the injury is, it can be anywhere because we're not really looking at mechanistic of that injury. Nothing is completely disregarded, but how is that injury play into the brain and the brain's perception of where that limb is and the brain's perception of what that limb feels like? So we're actually talking about brain-based therapies. We're not talking about physical therapy. Physical therapy is just done to the body. This is the body is a way of stimulating it. And trust me, every physical therapist or anytime anybody's working with you, they're stimulating your nervous system. That's the way it works. But let's get back to what clinical neurology is. And it's oftentimes, again, based on the vestibular system. And here is why. I'm going to pop up a whiteboard. So you're going to see this beautiful face fade away for a couple minutes. So don't get too upset. So hopefully you're seeing the whiteboard now. And what we're going to really do is I'm going to draw just a vertical line. And then we're going to draw, stick with me here. I know it's getting boring, but stick with me because this is where the fruit is, right? These are where the gems and the jewels are. So right now we're looking at a straight up and down line on the vertical axis is also called the y-axis and a horizontal line on the x-axis. This is a two-dimensional plane. We're not going to throw in the z-axis. There's actually three dimensions as we know, but the z-axis will come up and down through as a representation of what the third dimension is on a two-dimensional drawing. So we're not going to confuse us. We're just going to go two-dimensional here. And I say that because, man, everybody's a critic. Okay. So on this two-dimensional drawing, it's called a Cartesian plane. And if everything's perfect, a person lives exactly vertically perfectly, horizontal perfectly, and they're plumb. But guess what? As we get older, as we have injuries, as we have compensations, usually not the truth. So now I'm going to take this Cartesian plane and we're going to transcribe it into one of the biomarker tests that's performed called computerized dynamic posturography or posturography. So what it is it's a little scale that somebody stands on. It's super expensive and it's super sensitive. So it gives exacting numbers and exacting information. So on this scale, let's say that this is the hole. Try to draw a little box around it. All right, let's turn this into the machine. So an athlete's going to step onto this machine. And if everything is perfect, there's a bunch of different tests, but let's just say this one test here, if everything's perfect, the person's center of pressure is going to be exactly in the middle, and their balance is going to be pretty much in a circle. They're not just going to go around and around. What they're going to actually do is they're going to sway a little bit up to the right, and then back to the right, and up to the left, and down to the left, you know. But at the end of the 20-second test, we can ascertain that, they're pretty much stable. That's the best it can go. However, oftentimes what we'll find is somebody's center of pressure might be back to the left. It could be back to the right as well, but let's just in this case say back to the left. And what that means is that the weight of their body is nudged backwards and to that left side. So guess what? The back of that left leg is going to be tight. The back of that left glute and hip are going to be tight. They're going to be increased tightness there. The back of their lower back is going to be tight. So that in itself is a gem because we can understand that the person is compensating. And that compensation, if it's in the left side, would be holy heck, we need to change that. Now let's also get into the we were talking about the balance. And if our ellipse is in a circle, we can say we're stable. But oftentimes, and we're going to go back to this center of pressure, if their ellipse is forward to the right and backwards to the left, so it's a little off axis, that is going to actually show that and these are common because if you're on the left side, you're going to usually sway out of that quadrant. Now we're going to go back and try to understand what this means. And trust me, we can flip this the other way. So you could have somebody back to the right that goes up to the left and down to the right. But what we have is two things. We have an off center of pressure, and then we have an off center or a tilt of their ellipse. So we'll try to explain what that means. We're going to go back into that Cartesian plane. And we are going to say that this Cartesian plane is exactly plumb. That's the first one I showed you when they're in the center. However, the second one we showed you where their center of pressure was back left is going to be more represented. We're not going to get anything crazy here, but it's going to be a little off-centered. Like that. So guess what? It's not just their body that processes this. It's their vision system, it's their brain, it's their perception in space. And very minor, small amounts, so somebody is not totally contorted, they're going to actually see the world off axis. So that world isn't sitting perfectly up and down. Their perception is their reality. And their perception, they think it's straight, but their world lives like this. And so they feel, imagine if you're walking on a hill, or more, let's say you're driving your tractor and you're on the side of the hill, and the hill is tilted. The high side of the hill is up to your left, and the low side is down to your right. What do you think you're going to do? Are you going to lean in the tractor to the right side? No way. If you lean to the right side, you're gonna flip over and get hurt, and I could say a lot more crazy things, but that's what's gonna happen. So you're gonna actually lean into that hill, right? Because you know that that hill is not straight. It's a hill, right? Same thing goes with the body. That's why the center of pressure tends to be on that left side, and where we most often will sway out of that quadrant. So, how do we fix this? And vice versa, again, is true. How do we fix this, and what are we looking at? So, I'm going to actually draw this is anatomy, and we're going to say we got the cortex on both sides, and then we have the top of the brain stem called the midbrain. We have the middle of the brain stem called the pons. This is where the vestibular nuclei live, and there's four of them. So we have a medial, lateral, superior, inferior, and guess what? We actually have one on the other side. So we have, yeah, you have four vestibular nuclei on each side. So we're going to go back and we're going to still try to link this together in this first scenario where we said the back of the left leg is tight. The person is standing backwards on the left, but they sway forwards, right, backwards, left, and that their whole visual system is askew because they're off axis. So when we look at these, right, again, these are the vestibular nuclei. Let me type that in there real quick. And we have, again, we have them on both sides. We're going to say this is the cortex. And the cortex is the general of the brain, the biggest guy. So ultimately, if you have a good cortex, you're going to be doing pretty good no matter what. So we have again on the left and the right. We're going to say that we're going to call because we're looking at, again, two-dimensional, and this is opposite of X-ray. So we're going to say that this is the right side, and then obviously the other side is the left. Hope I'm not losing you because I go into detail a little bit too much. So in that first scenario where their center pressure again is back to the left, they're swaying out of the quadrant. What we really want to do is we want to stimulate this right pons where the vestibular nuclei live, and its buddy that lives right next to it called the cerebellum. So the cerebellum is really an outpouching of the pons in more developed species. So we got one on both sides. And while we're here, we got to say you got a bottom of your brain stem too that goes down into your spinal cord and crossing pathways. So the bottom of your brain stem is called your medulla, and so with this stimulation, we're going to stimulate again the right vestibular nuclei and the right cerebellum. And so there's a whole host of ways to stimulate it. But guess what? That person had a left knee problem or a left leg problem. And everybody went to that left side and did it and did it and did it. And it might have gotten a little bit better, but guess what? They're going to migrate their pressure even more, even more. And eventually, these young, healthy, completely fit, dedicated athletes are going to blow their knee out or blow their ankle out or blow their back out. And it's like, oh, I don't know why. Well, you didn't really look at them. That's why. So let's talk about some cerebellar stimulation. Well, we can stimulate the body. So we can do. I'm going to pop out of this share here. So we can do complex movements where we're actually going to move that limb to give stimulation on it. We're going to do stimulation with machines. So we might do what's called repetitive peripheral somatosensory stimulation, where we stimulate the nerves that are going to integrate into the spinal cord and come up and stimulate that cerebellum. We can do vestibular therapy, where we're going to turn them. And which way would we turn them? We're going to turn them to the right because the right side stimulates the right vestibular nuclei. And we might even give them targets off center down to that left side, up to that right side where they're swaying. So those are just two types of therapies that we can do. Um, we can do a ton of like soft tissue work and try to calm the actual area down on the other side, but that's not really brain work, right? Brain work's actually saying we're going to go in and turn the computer on so that computer is working perfectly. Okay, so please like and subscribe. I'm going to try to explain other therapies. We're going to talk about vision therapies, which are basically oculomotor or based on vestibular stimulation. So different targets that we can do. We're going to talk about other specific balance exercises and how that can work into the cerebellum and ultimately increase the frequency of firing into the vestibular nuclei. And while I'm thinking of that, now I'm seeing a ton of like vestibular therapists doing TikToks and Instagram things, and it's just so crazy because they'll have like a moving object on one side, stimulating movement, and they'll have the patient look to that side, seeing movement, and then the other side, and then they're standing on a foam pad, and they're bouncing a ball, and then they're moving their head back and forth and up and down, which looks it's just a ton of therapy. But is that therapy appropriate? And probably not. It's probably not, depending on the patient's neurology, the patient's central integration and function. Maybe it could be, but probably not. Most of that therapy is based on if you're seeing that crazy stuff, it's not what I do. That's not what my colleagues do. If you're seeing this stuff, most of that therapy is based on, hey, I had a virus that took out my inner ear on my right side, and now I have to adapt with the rest of my nervous system because I got a dead ear, a dead balance system that fires into the central nervous system. So my ear is something called peripheral. It's outside the central nervous system, but it's like a little receptor, and that receptor will poke down and stimulate it. And if that receptor dies, right? Uh-oh, I'm walking around like this. How am I going to survive? How am I going to thrive? Well, I'm going to just try to acclimate the person. I'm just going to give them a ton of other stimulations and see if that other side can make up for it or how that vision system is. So it makes sense, and a lot of times they can adapt well. This has nothing to do with what we're talking about today and how my therapy, clinical neurology, brain-based care is not physical therapy. You can use physical therapy, specific physical therapy exercises, but it is brain-based. All right, hope it makes sense. Stick around. I'm going to try to make some more videos. I'm going to try to dumb it down a little bit for all of us, make it make more sense. Um, Give me some comments. Tell me what you understand, what you want to know more of, and we'll get into it.